are going to go ahead and get things started. We've got a jam-packed webinar planned ahead. My name is Kyle Schuchter. I'm currently an emergency medicine pharmacist at The Ohio State University Wexner Medical Center here in Columbus, Ohio. Really excited to be moderating our second inaugural AEMP Career Development Committee webinar, our first one focused on culture follow-up. The webinar today focused on the pharmacist's role in emergency medicine medication administration. Got our flyer here for the webinar. We've got a great group of panelists that I will give some time and turn it over to here shortly to introduce themselves. But before we get into that and have our panelists introduce themselves, really just wanted to provide a little bit of background information for emergency medicine pharmacist medication administration. So I've listed here on the slide just different situations that we commonly encounter in our practice every day as emergency medicine pharmacists, where pharmacist medication administration can really pop up. We won't go through all of these, and this is certainly not an all-inclusive list, but some of the big things that you can see here are cardiac arrests, procedural sedations, rapid sequence intubation and post-intubation sedation, as well as our ischemic and hemorrhagic strokes, which I know all of us are very involved with and certainly have a very large role for EM pharmacist medication administration. I've also included here our different panelists and kind of what practices look like at their institutions. You can see here, Kevin and Jamie are in red, and they'll kind of talk a little bit about why here shortly. They are kind of working on getting medication administration up and running at their respective institutions. But you can see here for our remaining panelists, for Ryan, we've got two Ryans actually today, Ryan Feldman and Ryan Dillon, as well as Elise. You can kind of see what types or classes of medications these individuals are administering at their institution. You can see a pretty wide array across the board from cardiac arrest medications to sedatives and analgesics, thrombolytics, RSI medications, vasopressors and inotropes, and so on and so forth. So this just really kind of provides an overview of kind of what the scope is for EM pharmacist medication administration, really what some of those classes and medications look like that folks are administering in their ED. Similar to the last slide, I also wanted to include what some of the common routes of medication administration are where EM pharmacists are involved. Again, you can see a pretty wide array here from IV infusions, non-titratable and titratable, IV pushes, IV piggybacks, as well as some of our other routes of administration outside of IV, notably IO, IM, sub-Q, intranasal. Say for the most part, and especially with our panelists that we've got here today, inhalational medications are not something that most of us are administering at our institutions. I would say we rely heavily on our respiratory therapy colleagues for administration of inhalational meds. I've also included topical here, not something that pharmacists are super involved with. And at the bottom, rectal, not something that most of us are involved with. Certainly could be within our scope, but I think I could speak for everyone in saying that EM pharmacists are probably not super interested in giving medications via the rectal route. So without further ado, I want to turn it over to our panelists that we've got here today. We've got five wonderful panelists. We'll have each of them do kind of an introduction, describe their practice institution, as well as kind of what pharmacy medication administration looks like at their institution. Once we've had all of our panelists introduce themselves, we will turn it over for Q&A. Thank you for everybody who submitted questions ahead of time. We had lots of questions submitted, which is awesome. We will try to get through all of the questions that we can. If you submitted a question or have questions that come up as the webinar is kind of progressing that we don't get to, feel free to shoot me an email. I've got my contact information at the end of this presentation, and I can definitely follow up with our panelists to make sure that we get any questions answered. But without further ado, I will turn it over to our first Ryan Feldman.
Thank you very much, Kyle. Thanks for putting this all together. So my name is Ryan Feldman. I'm an emergency medicine pharmacist at Froedtert Hospital, which is part of a larger health system, Froedtert and Theta Care now. And we're affiliated with a medical college, and we have EM residents, pharmacy residents, and we're like a 50-ish bed, 70,000 a year visits, 24/7 EM pharmacist coverage, 6 FTEs filling that. And we do order verification, as it's stated there. And then in terms of our med administration practice, this has been in place for a few years, although it took us our first start at trying to get it in place was in 2016. But I think it was around 2021 we finally got it implemented. But we will administer medications when there is a need, meaning no other skilled hand is available to give the medicine due to a competing task or priority at that time, or just lack of staff and personnel. So we have a policy for it. It is written that way. It allows us to use our own clinical judgment as to whether or not someone else is available to give that med. And not everyone in our department even actually is certified to give medication. So it is requires specific training, which I can talk more about as we get into things. But there are some who are med administrative certified, and you get a badge to do that. Quite, kind of another piece of flair on your badge. And that's how we communicate with a lot of our nursing colleagues that, oh, this pharmacist is able to actually administer meds in this scenario where we need some task flexibility for resuscitation flexibility, right? So increased task distribution. We do it for anyone who has a secondary appointment in terms of anyone who's trained to work in the ER can do this. So you don't have to be an ER pharmacist. You could be quick care. You could be residents. We do include our pharmacy residents in actually doing this as well. They all get trained up. And as I said, not all pharmacists do it. I think those are the main things. We don't do chemo. We don't do intrathecal. I really tried for rectal, but nobody was on board for that. So I guess we'll just keep holding off on that one for now. But largely, it's just any injectable medication or oral, any of that. Do you want me to get into our, I think we'll go through everyone else first, but we can talk about the processes we have for training and policy and documentation as we go through. But that's kind of our spiel.
Perfect. Thanks, Ryan. I will turn it over to our second Ryan, Ryan Dillon. I did also include here on the slide, this was actually a publication from Ryan Feldman. This is published in AJHP. It's a really great publication if you are kind of interested in some of the logistics with EM pharmacist medication administration. A lot of these things we'll be going through today, but they've got a great publication. So I've included a QR code there that will actually link out to that specific publication.
Oh, thanks.
I will turn it over to Ryan. Second.
Awesome. I just want to say first, thanks so much, Kyle, for having me on here. Medication administration is something I'm super passionate about for many years, so I'm really pumped to talk about this topic. Like I said, I'm Ryan Dillon. I'm a clinical pharmacy specialist and team lead at Vanderbilt University Medical Center in Nashville. Our ED is currently 116 beds. We're a level 1 trauma, comprehensive stroke STEMI, really the only burn comprehensive center in the region as well. We see a little over 80,000 visits a year. That's roughly 8,000 trauma activations as well. We have 6 FTEs and a number of cross-covering pharmacists as well. We provide 24/7, 365 coverage, and we've been administering medications really for many years, but the official policy change came around 2022. It took several years before that to kind of get everything up and going and where we wanted to be. Kind of similar to Ryan, we administer medications in emergency situations, and we'll talk a little bit more, I think, later about how that's defined and how we got our policy up and running. But yeah, that's pretty much it. Thanks so much, Kyle.
Perfect. Thank you, Ryan. I've also included a link here to a publication that Ryan has been involved with as an author. This is a publication in the Journal of ACCP. Very great overview of EM pharmacist medication administration. So I've also linked that out there if you are interested in looking a little bit more at that publication. We'll turn it over to our third panelist, Elise.
Hi, everybody. My name's Elise. It's not Ryan. I know, shocking here, but I'm currently an emergency medicine clinical pharmacy specialist at the University of Kentucky. Our institution serves both adult and pediatrics, so we cover both sides of the emergency department. I think the technical number is 105 licensed beds, but out there right now, we've got at least 150 folks. So if you build it, they will come, and new hallway beds are created all the time, which is super fun. So we do see about 120,000 visits. And in terms of our coverage, we do have 24/7 and also 2 additional FTEs that support our community hospital. So in terms of our medication administration, we've been doing this for before my time. So in ye olden times before me, thankfully I have some excellent colleagues that kind of help set the scene for this. So I looked back at our initial pharmacist administration policy, and that was signed back in 2013. So we've been doing this for a minute. And in terms of, we'll talk about a little bit about policies and kind of how we support this. If we're not, I think, restricted in terms of emergency situations. And so we're often that extra set of hands kind of in every scenario to help facilitate medication administration. I'm very biased. It's one of the things I love about my job because I have no patience and zero chill. And so if I want it to happen, then I'm going to give it. So thankfully, we have the support to do that, which is really nice. And honestly, probably spoil our colleagues quite a bit with the approach, but it does help expedite appropriate pharmacotherapy. Our residents do participate this and kind of get oriented at the start of the year. And although most routes were listed on there, rectal was not on there. However, I will put that caveat is several of our residents, not your girl, in previous years have administered that rectal aspirin for a STEMI. So nobody told them to do that, but they did it. So Technically, could we? Yes. Do I want to? Absolutely.
Awesome. Thank you, Elise. That is some dedication right there. Administering meds via the rectal route as a pharmacist. I will turn it over to our fourth panelist, Kevin.
Hi, everyone. My name is Kevin Mercer. I'm an assistant professor of practice at the University of Texas at Austin, but I work primarily in the Houston area at various HCA Houston healthcare hospitals, my primary site being the Kingwood location. Jamie and I's part in this is kind of unique. So we're kind of a package deal, and we'll kind of get into that a little more as we chat, but I want to toss it over to Jamie to introduce herself really quick.
Yeah, hi everyone. My name is Jamie Stair. I'm a current EM pharmacist at Baylor University Medical Center, or BUMC, in Dallas, Texas. Like Kevin said, I cannot administer medications at any of the Baylor Scott and White locations, but we are currently working on a project to kind of evaluate that in the state of Texas. Something I hope to implement at our practice site because we are a very large teaching hospital. We have 85 beds, but as we know, all the borders and hallway beds add to way more than that. We have over 100,000 annual visits. And pharmacists have a huge role in the ED. We have 7 FTEs, 24-hour a day coverage.
Yeah, so like Jamie was talking about, in Texas, the law is currently unclear. So there are some sites that I've been at that pharmacists do administer medications, especially during emergencies. And there are other sites that, like, for example, in Jamie's area in Dallas, that are a little more strict and take an approach where we don't, but hope to chat about this more as we progress.
Awesome. Well, thank you to all five of our panelists for taking some time out of your busy schedules to chat about a topic that is near and dear to many of us. We are actually going to launch our first poll question. We've got quite a large number of folks on. We've got about 96 folks on the webinar, which is great. I think one thing that we're all curious is to see how many folks on the webinar are actually already administering medications at their institution. So Aaron, if you want to go ahead and launch our first poll question, this is really just going to ask if you are currently involved in administering medications at your institution, just to see kind of what the spread is for everyone who is logged on for the webinar this afternoon. Okay, we've got about a little over 70 folks who have responded. The majority are not currently administering medications at their institution. A little over a quarter are currently administering meds at their institution. So hopefully for those of you who are not currently administering meds at your institution, hopefully this webinar will kind of give you some logistics to kind of take back to your institution and really hopefully answer some of the outstanding questions that have come up or your team has had related to pharmacist medication administration. Perfect. So we are going to go ahead and launch right into our questions. Again, thanks for folks sending in questions ahead of time. We've got a lengthy list of questions for our panelists today. We will try to knock out as many of them as we can. But first, just kind of starting out, I think Ryan Feldman, you had kind of alluded to this a little bit. I think one of the big questions that comes up related to EM pharmacist medication administration is really just like implementation of this. So I was curious for both of our Ryans and then also Elise, if you could really just talk about how you all have implemented this at your institution, and especially any pushback or barriers that you guys have encountered. And we can start with you, Ryan Feldman.
Sure. So this was kind of a journey for us. So when I was in a PGY2, when I was graduating, I have emails from 2016 where I was emailing the ACCP listservs like, who's administering meds? How are you doing it? We want to start trying. We had a law in Wisconsin that anyone could, basically we were already doing a lot of this stuff. We were doing like pump manipulation, hooking up pumps, hooking up IV lines and pressing, go. So we were already doing some stuff. We're like, we should probably have some policy in place. We'd like to be protected if we do this. In 2016, we tried to implement a policy based off a law in Wisconsin that says a pharmacist can do anything as dictated by a physician. So we're like, well, that seems really broad. We'll try to do this. We got a little bit of pushback from nursing and risk at that time. It was just kind of a new idea. People weren't super into it. In 2021, after some lobbying from a state pharmacy organization, pharmacist law went into place that pharmacists could administer non-vaccine injectables, meaning any medication. So we then worked with our nursing colleagues and our administrative colleagues to put together a policy who said, hey, pharmacists can administer meds. It's in the law. They should be able to do it here when needed. So we put that together, brought it through the appropriate avenues. Risk at our hospital actually pushed back. They were the only ones who were like, I don't know. I don't know if these people who are legally allowed to do this thing that's within their license should be able to do it at this hospital. And eventually, because we had enough buy-in from nursing, from the ED providers, and from our own pharmacy administration, We just sat down with risk and said, we understand you're hesitant, but we're going to do it. We did a risk assessment because at the end of the day, risk doesn't take care of patients, right? So we did a risk assessment for them. That was part of the bargain and said, here are the possible risks and here are the benefits, and we're going to move forward. And then we implemented it. We also had some difficulties that were associated with the long-standing debate of where pharmacist services are needed. Should you be in a basement behind a computer just verifying orders? Should you be at the bedside during emergency resuscitation? Or is that taking away from your orders? Or is giving meds also taking away from the cognitive services that you can, get? I think there's a huge spectrum of this where people lie. Even within our own department, there's some people who were like, I don't really want to have to do more at the bedside than we're doing. So we implemented a scenario where if you wanted to do the training, you could do it. And we delineated who could do it based off of a badge. And this allowed everyone to basically take part in as much as they wanted. It's always hard to get pharmacists to agree on things. So that was our compromise. And I think it worked out really well. So now those people who want to be able to increase task flexibility and work distribution during a resuscitation can. And those people who feel like it's gonna be too much of a distraction from their border orders, they can work on their border orders. And that's kind of where we lie. We do have training that was required. I can just show you real quick. I'll keep this as, can I share? Is that okay? My screen?
Yeah, absolutely. Let me know
Okay.
if you need me to stop sharing, but you should be able to.
I'll show you just because I have some stuff pulled up. But this is our training that we do. So in Wisconsin, you have to do a pharmacy examining board approved training protocol, which actually was created by our PGY2 EM resident when the law came out. They created the training. It's a half-hour video on the 5 rights. And then we have our policy for pharmacist administration, which basically says anyone practicing in the emergency department only is where we're going to administer it. And then you have to have training on IV pumps, and you have to get 15 sign-offs. So you do 5 IV infusions, 5 IV push, and 5 intramuscular. It gets signed off by the nurse who does it with you, and then that gets held on by our administrator, and that's it. So overall, you do get some nurse training. You do a video that we actually created and had the board approve, and you have to have those in place. And then you get your badge and you're good to go. And that's kind of our general gist of how we did it at our hospital.
Yeah, so I kind of alluded to this. We started, the official policy got approved in I think September of 22, but it's been an ongoing process since I got here in 2017, give or take. I think we're a little bit more fortunate in Tennessee than up in Wisconsin. Our law was already in play and it was really didn't have any restrictive language. It said in the scope of pharmacy practice, you can administer medications. And then it further goes to define administration to include injectable medications. And it really ends there. So we're very fortunate in that regard. So we really just had to focus on the hospital policy side of things. We really started with just brainstorming, what we actually wanted to do. Everyone was kind of on board in terms of EM pharmacist. So we kind of decided, hey, we want to focus our time and energy on high risk medications and resource limited situations, kind of what Ryan was talking about as well. We drafted these up. We talked to our key stakeholders. So really getting the director of pharmacy, the chief pharmacy officer on board, who is very involved in the Tennessee Pharmacy Association. And they, on behalf of us, reached out to the board and said, hey, is this interpretation of the law, what you guys agree with, which I think was big. And they said, yes, we support this, pretty clear that you guys are able to administer medications, including injectables. And then it was just getting support from our ED nursing staff, our nursing leadership, ED physician leadership, which were basically, we kind of see you guys do this already. What's the change? It's really just putting it in writing, right? So yeah, the next was just to draft up a policy change. We already had medication administration policy. So we kind of said, hey, what's the pharmacy verbiage in here and how we make some changes there, which I think we'll talk a little bit more later about. And then we made an SOP as well to say, hey, how are we going to comply with this medication administration policy? But yeah, the next was to work with policy and risk and legal. We didn't receive a ton of pushback. I think, again, we had such great law verbiage that really helped us there. But we did receive a little bit of legal, it was on the nursing end, a little bit of pushback, but it wasn't anything kind of long and drawn out. We were pretty lucky there. So I think strategies that we found helpful. So getting in touch with the board up front, to be like, hey, do you guys support this? Does this make sense? Getting help from like other institutions. We reached out to UK, for example. But yeah, just really like those face-to-face conversations were really helpful up front. So talking to our nurse leadership, anyone who's going to like see this SOP or policy come across their desk, or they're going to have to vote on it at one point or another. We as a group kind of tried to get them involved up front and answer any questions or concerns they may have to kind of relay what our plan was. And yeah, it was ultimately pretty successful. So 2022, we got approval and we started training. We have an online module and an in-person, which I think we'll talk about again in another question or so. But yeah, that was our process.
Yeah, and last but not least, the not Ryan. No, for us, I think I'm very spoiled in that this had been established long before my time. So with our in-house on-call program that's existed for many years at this point, our role in stroke response and preparation and administration of alteplase have been pretty well established. And so thankfully coming into it, we were kind of backwards in a way of we had been doing all of these things and we're like, oh, we should probably have some stuff in place that covers us and make sure that everybody is on board. And so collaborating kind of similarly a process with nursing leadership as well, because of course they were like, yeah, you guys do great. We'd love to have you, all those things. We'll have a policy in place that basically supports you guys doing this. And then in terms of kind of training, continued development, so we have that policy in place. We do orientation with the residents and they have specific WBTs that we have them watch. So that's web-based trainings, lots of fun, super interesting videos. So we align those with the things that the nurses are supposed to watch and each year. So on an annual basis to make sure that we're staying up on our med admin skills based on these high quality web-based trainings, but also making sure that we do some at the bedside verification as well. So not as nice as Ryan's checkoff list. A lot of it is the standard kind of see one, do one, teach one, but kind of repeating, modeling these things, giving them those experiences. We also have a nice, again, very interesting, hilarious pump video to watch to get a better understanding of how to utilize that equipment and kind of, walking them through where to find various things in the pump, because as we all know, that can be a challenge in those critical times. So in terms of pushback, I mean, we very little, which is very nice. Like I said, incredibly spoiled by the precedent that's already been set for many years. So really it was just formalizing some of those processes. And for us, especially Kentucky law, again, it's not explicitly, yes, of course, pharmacists should be administering these medicines like in the settings we're talking about, but it doesn't really prohibit it. And so there's a lot of flexibility in that law and support in the verbiage, but not super specific. So that gives us a lot of leeway to do what we do, which is nice.
Awesome. Thank you all for sharing a little bit about how you all have implemented the medication administration programs at your institution. As we saw with our first polling question, I think most of those on this webinar are not currently administering medications at their institution. I want to turn it over to Kevin and Jamie for our next question. I know they shared a little bit in their introduction about kind of what things are looking like at their institutions, but for lots of folks, their State Board of Pharmacy has either very unclear verbiage or potentially specifically outlines that pharmacists are not able to administer medications. Kevin and Jamie, you both are very involved with an ongoing project to kind of help get medication administration up and running at your institutions. Can you both kind of expand on that a little bit and some of the work that you guys are doing?
Yeah, so thank you for that question. Our project really arose from me chatting with Jamie about one of her patient cases, I believe, and how she shared that, oh, well, we're not allowed to administer medications in Texas. And I was like, wait, really? It's in our Texas State Board of Pharmacy, like legal phrasing. And so we kind of pulled it up together and looked at it. And honestly, it just kind of took off from there. Like we reached out to someone at the Texas State Board of Pharmacy. We have a whole team of pharmacists, mostly emergency medicine pharmacists across the state who are working on this project with us. And so we're essentially trying to develop a survey for administrators on how they are interpreting this language to see if there are like any sort of regional differences in pharmacy practice and medication administration by pharmacists across Texas, since Texas is so large. Jamie, do you want to chime in with anything?
Yeah, so I guess to add to that, the purpose of the project was really to survey all of these different stakeholders, like administrators and inpatient pharmacy, that would kind of be making these hospital protocols and assess really what like their interpretation of the law is. After going through residency, I've become a pharmacist in 3 separate states now, so I've read the law on all of these, and it doesn't seem like Texas's law is really written much differently than some other states, but it is the way that it is inconsistently like interpreted across the state. It was very interesting. So we wanted to kind of assess that and assess like what people are interpreting the written law to be and compare that to what the board intended. So we've kind of developed that, run into a little bit of hiccup when it comes to the Board of Pharmacy part and their ability to elaborate beyond what is actually written. So it is kind of added a hiccup to our project, which Kevin and I are still kind of working through and figuring out how to really clarify this with the board, because we just want to provide the information out there for all of these folks that are practicing and administering meds when maybe the board is intending not to, or vice versa, when hospitals are interpreting that we shouldn't be administering when maybe we could be by the board. So it's kind of the purpose of our project and what we're actively working on to clarify.
Right. And so one of the biggest goals of our project is to provide the information on like the regional disparities in practice and really kind of hopefully show the Board of Pharmacy that there needs to be additional clarification on this, and we need to make it clearly like one way or another. As emergency medicine pharmacists, we obviously hope that this project will allow for an expanded scope of practice within pharmacy. But yeah, Ryan, you had your hand up. Did you have
Sorry,
a
yeah, I wanted to jump in and ask because we were bringing up, and I saw in the chat, a lot of people deal with ambiguity around the laws. They're so confusing. We're
Yeah.
not lawyers. And the article that I wrote with some colleagues from Ohio and California, the Ohio contingent had to reach out to their board of pharmacy specifically to clarify, like, does our law preclude me from doing this? And their board of pharmacy actually said, doesn't seem like it. And they were able to give that to their administrators, and it was a big spur for them to actually implement med administration in Ohio at their institution. So, are you saying that Texas was kind of like, I'm not sure? Or
So you bring up a good point, and I see your point here in the chat as well with involving the Board of Pharmacy. So we have at this time involved the Texas State Board of Pharmacy, but they seem sort of like the reluctant to be super involved in the project just because of, being involved in like kind of QI in general and how it may change or interpret the law. They've made it clear that they don't necessarily provide legal advice. So it's been an interesting partnership, but we are still hoping to work with them to provide some sort of clarification.
Thank you both for sharing. I think that'll be very helpful for folks who are not currently administering medications at their institution, just kind of what some of that legwork looks like and kind of what some of those first steps are to kind of get this up off the ground and running. We're going to transition to our next question again. This will be for both of our Ryans and Elise. I know you three kind of already touched on this a little bit, but if you guys have anything else to add for this question. I think a lot of individuals are really kind of intrigued and interested by what the training process looks like at different institutions for EM pharmacist medication administration. So, we've kind of talked a little bit about some of these things, but competencies, online modules, IV pump programming, nursing involvement with training, which I know Ryan Feldman, you had mentioned a little bit, formal competencies, as well as kind of ongoing annual competencies. So for the three of you, do you guys have anything additional to add for what kind of that training process looks like?
I nothing much more other than the fact that the reason we watch a video is because it's in the law that we have to do a training course that's approved by the pharmacy examining board. It's really not very helpful. The really helpful thing was working with the nurses and learning how to, I mean, we don't get any training on this, so learning how to flush the line, check for blood drawback, standard checking for patency, that was really helpful. So if you don't involve nurses, I totally, I think at this point, a lot of us, I know it's a battle everywhere you go. And when we originally tried to do this, the nurses were kind of like, oh, another thing the pharmacists are going to do. But now they're like, oh my God, absolutely. Why are you not doing this? So just trying to get a nurse, learning from your nursing colleagues is super helpful. And I would recommend if you are implementing this to get someone involved, a nurse manager who can just, I mean, it's a very basic skill. It's just it's helpful to have someone who's been there before. So.
Yeah, I would totally second that. We were fortunate enough, one of our neuroclinical pharmacists was formerly an ICU nurse and then went back to pharmacy school. So we're like, you are the perfect person. So she jumped right in, and it was her and myself that kind of developed the whole education portion for ours. So we have an online component that kind of goes over the policy and just kind of troubleshoots and talks about a variety of things, including the 5 rights. It's like not like Wisconsin, we don't have anything in the law that says you have to go through any kind of education. So this is all homegrown just within Vanderbilt. But we have the online component, and then we have an in-person session that we put on a regular cadence in the beginning to get everyone up and going. And now it's just kind of as needed. But our hands-on portion, we talk a lot about policy, documentation requirements, line recognition, so peripheral, central, how to recognize an A line versus a peripheral line versus a dialysis catheter, et cetera, for those people who aren't as familiar. Line patency, troubleshooting. We actually have like a dummy IV set that we set up, and we clamp the tube so they can kind of feel how it is, and if it gets kinked, et cetera. We do a lot of work with pump programming, so we run through a variety of situations. We use Alaris here, and then extravasation management and policy. But yeah, definitely totally agree. Get nursing involved as much as you can. They're going to be kind of the experts to lead you through this. We have ACLS required as well. And then yearly, they take that online module again, and there's test questions at the end. So that's kind of the annual recertification for us.
Yeah, and I don't have a lot to add in terms of what already has been said. Definitely relying on your nursing colleagues, especially for some of that initial training and understanding and real life practice, to be quite honest. I use them. I think that was one of the questions in the chat is kind of how are you verifying patency? What is that like? Because especially when we've not been trained to do that from, pharmacy school and haven't done that a ton in clinicals, it's definitely a big shift in mindset and how you give things. You're like, I know how fast this is supposed to go. I know what I should expect, but like, how do I know if this is good? So definitely first step, especially even at the bedside, even to this day, and I've been doing this a while now, is hey, which line is best? Have you already checked these? If not, okay. And just the other day I had one where I was like, guys, it doesn't feel good. Is it me or is it the line, right? Sometimes it's me, but in my defense, sometimes it's the line. So definitely implementing your nursing colleagues to help guide some of this is super helpful. So just reiterating, use your friends, use your resources to not have to reinvent the wheel.
Thank you all for that. Ryan Johnson, you've got your hand raised.
Yeah, appreciate the conversation. I just wanted to kind of throw this out there and get the feedback from the panelists and also maybe read the room and how they interpret it. So right now in the state of Florida, trying to work with a local pharmacist legislator to try to amend the language of the Florida statutes to include administration of medications for pharmacists, because like other states, the language currently does not explicitly allow the word administration and the definition of pharmacist practice. But one of the things that in dealing with other lobbying organizations, such as the medical associations, that they've raised concern with is pharmacists proving to be competent to administer medications, right? And that's kind of the whole purpose of this meeting. But the conversation that we were having kind of originally started with any ACPE accredited college of pharmacy, which is all of them. One of the mandated part of the curriculum is medication prescribing, preparation, distribution, dispensing, and administration. So trying to kind of push back from the perspective of, if you have a 4-year doctorate of pharmacy, have you proven competent to be able to perform this action? Now, does that mean you're comfortable with it? Certainly not. Does that mean you still want repetition or there's more to be learned? Certainly. I'm sure the first time anyone dosed vancomycin, they probably were not comfortable, even though they might have been deemed legally competent to do so. So just curious if anyone feels like, does the barometer of graduating with a PharmD from an ACPE accredited college of pharmacy at least meet the legal minimum standard for administration of medications? Now, certainly I agree with some of the extra training, maybe refresher documentation on pulling and pushing art lines, venous lines, central lines, etc. But I also feel like maybe I'm the odd man out that after graduating from pharmacy school, we should all at least have the competency to be able to appropriately do this. We're exactly telling nurses how to administer medications. For us to take our own advice doesn't feel like that far of a stretch, but curious if I'm the only one that feels that way.
I would just posit that unequivocally, yes, it does mean, who the nurse is going to very limited. There is no class in nursing school on how to give an IV. They learn this on the job. There are emergency department technicians who are unbelievably skilled people who go to 6 months of school and can place an IV. This is well within our wheel set, and there is a cultural shift that needs to change. You could give an intramuscular injection. Everyone decides we're competent enough to give an intramuscular injection so we can vaccinate the world. You can give an IV, which is actually easier. There is no anatomic site, landmarks you have to try to pick out. You just are pushing a plunger down and making sure the vein is patent. So there's just, we have a huge PR problem, as you know. And training, for 6 to 8 years plus residency seems like plenty of competency to me when our colleagues doing it have gone usually to school for much less than that.
Any of our panelists have anything else to add for that question before we move on to our next polling question?
No, I completely agree. That's a good summary right there.
Perfect. Well, we are going to keep moving on. I think one thing that has come up is really just liability for EM pharmacists who are maybe administering medications. Aaron, if you want to go ahead and launch our second polling question, just kind of wanted to see what the spread is for folks that are on the webinar today. I think one thing that a lot of us are told is that our institution kind of has liability insurance for us, but I know a lot of individuals have their own personal pharmacist liability insurance. Curious to see what the spread is in terms of folks that kind of have their own individual liability insurance versus those who really just kind of have what is offered to them through their institution. Aaron, if you want to go ahead and launch that question, we can kind of see what the spread looks like. Perfect. So this is really just asking if you have personal liability insurance outside of what your institution may offer to you for pharmacist liability coverage. So we've got quite a few folks who responded. It's pretty close to an even split. I would say more do not have personal liability insurance. They're just kind of covered under their institution. But curious, Ryan Feldman and Elise, if you guys have any thoughts to add in terms of whether or not you guys have personal liability insurance and maybe any commentary on if you recommend it and any logistics with that.
Yeah, I feel like it's mixed on our team. So I would say there's some that do and some that don't. I feel like I say this in practice and in real life. It's trust no one. It's not even trust but verify, trust no one, right? In a sense, right? Of if you're putting yourself out there, this is kind of increasing your liability in terms of your care for the patient, then it doesn't hurt to kind of have that backup in place to further protect you should the institutions be insufficient, right? So I'd say it's mixed on our team. I know there's a few that do, a few that don't, but my thoughts is we're doing more. So with that comes more responsibility.
To follow up on Elise's point, one, I also have personal liability insurance, but I'm not really included in this part of the webinar. But as far as personal liability insurance, it was recommended to me to check with my coverage provider to make sure that it included medication administration because they were like, if this is like a gray area within the law, maybe it's also a gray area with your insurance. So I would urge everyone to once like if they're going to implement something like this to make sure that they're also checking on the back end with their own personal liability insurance, which I would definitely recommend the 2/3 of you that recommend that reported that they don't have it to get it to see if it is also going to cover you for that.
Yeah, I second that. I do have my own because I understand an institution. I understand I've worked on do some expert witness work, and I do have a feeling that insurance companies will try to find any reason to not pay money. It's my own personal perspective, but I've seen some, people look for loopholes. If they don't have to pay $2 million, they're going to say, oh, no, and they're not allowed to do that, and we're done. So I'm actually fortunate that I think I'm covered by my hospital, but also I know that hospitals will sometimes, if there's something they think is going to negatively impact them, I don't think they are all above throwing their employee under the bus. Ryan Dillon might be able to comment more on that or not, understandably. So I have my own insurance. I also have errors and omissions insurance, but I don't know if that would cover this, but it's kind of a separate thing for some other work that I do. And I think it's just a personal line people draw in the sand, whether they think their hospital will, fully cover them. But I would say if you're going to lay on that, it's important to have a policy in place because then you're saying, well, I'm just following the procedures that are quite documented within our hospital. So.
Awesome. Thank you all for that commentary. I think that is helpful. And that was a question that a lot of folks submitted ahead of the webinar. So I think that will provide some really helpful insight for individuals who are maybe already administering medications at their institution and maybe don't have personal liability insurance to kind of weigh some of the pros and cons of getting their own personal liability insurance versus really just kind of being covered by what is offered at their institution. I'm going to turn it over to Kevin and Jamie for our next question. I know you guys are heavily involved with your project, kind of to get medication administration off the ground and running. So, for the two of you, if you both were kind of implementing a minimal viable scope administration program at your institution and kind of had to prioritize three medications or medication classes for EM pharmacists to be able to administer, what would those three classes or medications be for the two of you?
Yeah, I think that prioritizing medications that would be given during emergencies like ACLS would be important. Jamie, what do you think?
Yeah, I mean, a lot of the standard ones that those that are already administering kind of acknowledge, like ACLS, RSI, traumas. I think any of the ones that have like time sensitive metrics, both that are looked at by like CMS or reaccreditation, or ones that just have better benefit on like patient outcomes, like our ACS, stroke, sepsis, things like that.
Yeah, I think this is a big
sorry.
one.
Yeah. And then I was thinking something institution specific for us. We have like very high acuity patients and we do a lot of intubations. I think for me personally, one of the biggest impacts for my own practice would be analgo sedation and vasopressors and just really being able to initiate what I need, titrate it how I need, let everybody else's have hands free doing their own stuff. Nurses have so many other jobs to do. I feel like they don't need to hit all the buttons on the pump every 2 to 3 minutes just to titrate stuff.
Yeah, I think vasopressors would probably be my number one.
I would agree. I think if I were kind of picking three medications or classes, I think all of those would be kind of high priority. And definitely at my institution, our EM pharmacists are very heavily involved with all of those medications and situations. So I think prioritizing those could be very helpful if you kind of had to implement kind of a minimal scope type practice at your institution. We're actually going to transition to our third polling question that comes up a lot and was submitted by several folks before the webinar, is whether or not manipulating a smart pump actually constitutes medication administration. I think that's kind of one area that is a little bit unclear. So Aaron, if you want to go ahead and launch our third polling question, I'm curious to see what those on the webinar kind of think and whether or not manipulation of a smart pump really constitutes administration of medications.
This split is really interesting, Kyle.
Yeah, I am very intrigued. So we've got pretty much a 50-50 split with actually whether or not individuals think manipulating a smart pump really constitutes or is considered medication administration. Kevin, I know you're also intrigued. Any commentary to add for this?
Yeah, this has come up quite a bit during our designing our project, and I think it was actually a Kentuckyism that I came with because I'm from Kentucky. I went to school at UK, and I think it was there that I learned that, manipulating a smart pump was medication management. It wasn't necessarily medication administration. I don't really know where I land anymore, to be honest, but I did mention this to a couple of administrators, and I was like laughed at that. Of course, that this is medication administration. That would be ridiculous not to be things like that. I'd love to hear Elise's perspective on that.
I mean, since I could do it all, I was like, I guess I don't know where that came from necessarily, but I feel like setting it up is just like being that double check. So if you're not the one, I know some people have they can do everything but literally hook it into the patient or hit the start button. So, if I didn't have the powers in these hands, I would probably I would hope pump management wouldn't count. I'm using the word management, so maybe that did come from me. But I would say not medication administration versus just actually pushing the start button and administering it, connecting it to the patient. All those things would be more of the admin part.
Kyle, I think I might have something to add here. I think this question just, and especially with the 50-50 split, it just kind of solidifies like this is a gray area. This is what we're talking about. And it's really like we're arguing if we get a question at the end from either administrator or legally, like what is the argument back? Right. So for a while before our policy was set, like we would do everything but hook it up to the patient. Or I'd have the nurse come over, can you press start after I did everything else? And it's really, can you argue? Did you administer it? Did you not? I don't know if there's a clear answer. That's going to be honestly probably up for a legal decision, but it is a nice gray area, and it shows that we're pushing the practice, honestly, if you're living there. So that's just my 2 cents.
Well, we were before we had our policy, we were doing this. We were hooking up meds and pressing start, and we were like, well, it's not med administration. We're just hooking up a pump. And then something happened. I think it was an error. I wasn't involved. But then all of a sudden it was like ER pharmacists are no longer allowed to set up pumps. Not set up, but like press start. And because then we were defining that as med administration. So then we were like, well, fine. Now we need a policy because if we're not going to be able to hang our vasopressors and do this, like we're really going to run into problems. So it has changed for us over time. And on the other side of the fence, where I'm now allowed to give meds, I'd say yes, it is med administration. Before that, I'd say no because, and that's really where I land. But like, I mean, hooking up to the lure lock is about as technical as, that's honestly more than pressing start. So like, which part of that is administration? Yeah, exactly. This is a gray area. And I think the answer is whichever allows you to have the most autonomy.
Yeah, I would agree. I think it's very much a gray area. So I appreciate all the great commentary on whether or not we really consider that medication administration or not. I'm going to turn it over to Ryan Dillon for our next question. I think one area where some ED pharmacists maybe get a little nervous or worried about implementing ED pharmacist medication administration is really just kind of related to that slippery slope of if you start giving medications, you're going to be expected to give more. And how does that kind of detract from all of the other clinical responsibilities outside of medication administration that we're involved with on a day-to-day basis? Ryan, do you have any commentary to add or any thoughts on how you guys have kind of navigated that slippery slope?
Yeah, this is a great question. And one we thought about when we were drafting that SOP and change to the policy. We wanted to be as helpful as possible, but not, commit to something that we really can't. I'm going to read to you a little bit about like the SOP and how we define it. And I think this is where this will answer the question. But our SOP specifically says pharmacists who receive training may administer medications during emergency response situations, including but not limited to stat response, code stroke, RSI. So it kind of leaves it in our hand. We left it intentionally gray to allow us to make that decision. Is this emergency response? Does this warrant our help? And that's where we kind of had that including but not limited to. But yeah, emergency only, that's kind of how we do it. We also have a number of medication routes that we don't administer, kind of what Elise and Ryan were already talking about, intrathecal, et cetera. But I think kind of putting that in where we leave it in our hands to make that decision helps us not commit or overcommit ourselves to that slippery slope in other situations.
Yeah, that's very helpful. And I think Ryan Feldman, you had shared earlier some of the verbiage that you guys have in your SOP. I think some of that specific verbiage kind of helps mitigate that slippery slope because if you're asked to do one thing, you're going to be asked to do constant things. And I think kind of maintaining a good balance between all of those clinical responsibilities when we're throwing med administration into the mix is really key. I'm going to transition to our next question. Ryan Feldman, I know you had mentioned this earlier with training. I think another kind of point of clarity at some institutions is whether or not every member of an EM pharmacist team feels comfortable administering medications, especially for teams that are larger and have maybe 6, 7, 8 ED pharmacists. Ryan, I know you shared this a little bit earlier, and I've got a picture that I can share with folks from the slide deck, but how have you guys navigated maybe EM pharmacists within even your own team that maybe aren't very comfortable administering medications?
I think we luck out that the ER over indexes in pharmacists who want to do non-pharmacy, non-traditional pharmacy things. So most people, are like, hey, we're here for to help, and however that is. No, we really, because we made it essentially elective, there is no real pushback because, okay, well, don't do it then. I don't know what to tell you, right? If we had to try to unify everybody, it might be harder. I think actually where we wound up with pushback is some of our third shift coverage, they have to cover several other ICUs plus the ER. And I do think they were worried more about the slippery slope of like, well, am I going to suddenly, I already have to come down for like, this person fell out of their wheelchair trauma. Am I now going to have to come down and start giving cephapines, which is why we built in the language to help prevent like the slippery slope issue. And we really have had zero problems. I've only ever had like been able to use this to help patients and never been drawn away from other work to have to do this. So that has really helped us navigate this. And it was really about setting expectations and clear communication with the nurses. Some people refuse to get the badge, but they still give meds anyways. And I'm like, okay, whatever. I don't know what you want from me. But because we were, everyone is in this scenario where you have someone sick in front of you and they need a medicine. I mean, a lot of times people make the choice to help the patient, right? Whether they have that credentialing or backup or policy set in place or not. And that's what leads us to end up doing these kinds of things. So we have people who have done the certification and give the meds and feel confident in it. We have people who didn't, but they still do it. And we have people who have not done it. And that's kind of where we land.
Yeah, I think without us having, we have a pretty big team. And I think when our folks bring them in, the scene is set of this is the expectation and this is a part of your job. And so I say like non-optional. Now, can they hand things off in various scenarios? Like no one's going to force them to administer the rectal aspirin, right? So with limitations. But I think the interesting question about the slippery slope and kind of being brought into a lot of things is it's so great that we can help facilitate care for these patients and help expedite some of these pieces and do so in a safe manner. However, sometimes it does happen where we're a busy level 1 trauma center. We have adults and pediatrics, and there can be concomitant patients that are needing attention. And so since we've spoiled them for many years, I think that has somehow now swung the other way to a certain extent where it's like, we need you for this season, kid. I can't get the benzos, and it's sometimes a trial to be like, yes, I understand. You can override it. You have my blessing. Please, dear God, give the benefit, right? So I will say that is something that I think within y'all's policies is nice to have, and kind of that understanding is these are the things with which we are going to prioritize doing versus getting looped into all of the things. Now, that can be restrictive at times because can I give my antibiotics for open fracture? Absolutely. Can I, help facilitate these time dependent manners? Neutropenic kiddo comes in, helping to get those on board. Absolutely. So there's part of me that loves not having restrictions, but then there's also part of me on the days where, we're literally chest deep in somebody, doing a trauma code, and they're like, oh, they're having a reaction. Can you get the IM epi? And I'm like, y'all, I need you to figure this out. So that is something to factor in as everybody's working on these things and developing your policies, is kind of what do you have the bandwidth and capacity to do, especially without, depending on number of pharmacists on shifts, et cetera, and acuity of the.
Awesome. Thank you both for that commentary. I think that's extremely helpful. We are already nearing the end of our hour block. Thank you all for joining us. We're going to end with kind of a two-part question for Ryan Dillon that I think a lot of folks submitted ahead of the webinar. And that really relates to whether or not EM, or really pharmacists in other specialty areas, so critical care, cardiology, if those individuals at your institution are also having the ability to administer medications. Kind of part two to that question for you, Ryan Dillon, is whether or not your kind of privileges of administering medications kind of extend outside of the ED. So I don't know if you all are kind of involved in floor codes or responding to medical emergencies outside of the ED, but really whether or not those privileges of being able to administer medications extend in practice settings outside of the ED.
Thanks for the question, Kyle. So when we first implemented our training, we prioritized people who respond to codes and our EM pharmacists. So that was the priority for each session. I think we limited it to like 3 people per hands-on session. But since then, we've opened it to everyone who has a PharmD, basically in the adult hospital. So that includes some of our central pharmacy folks. Now, they're probably never going to have that situation, but just going through the motions with the Alaris pump and pushing meds and extravasations, like they get training, we get FaceTime, and they're better able to answer questions that they may get in central. So we definitely open that training up to everyone. I will say EM, we actually, in the paper we published, we looked at who was administering. And at that time, it had only been going on for, I think, 6 months to a year, something like that. It was all EM pharmacists. But anecdotally speaking, CVICU, CCU definitely does a lot of this. All of our residents go through this training, so they're able to administer epi during codes or wherever it is. Definitely seeing them do that outside of the ED, up on the floors during floor codes, everywhere else. So once you go through the training, you basically are free reign to do what you want there. So yeah, it's happening everywhere.
Awesome. Thank you, Ryan. That is very helpful insight. I think that question came up quite often. So really good to have kind of that commentary related to that. We are already a little bit past the hour. I want to thank all 5 of our panelists for joining us this afternoon and everybody joining the webinar. We had great turnout, a little bit over 100 individuals joining the webinar at one point. I think really great discussion. We did not get to everybody's questions. So if you guys have any outstanding questions, definitely feel free to reach out. I will put my email up on the slide. If there are any outstanding questions, absolutely feel free to email me. I can connect you with all 5 of our panelists. I'll also send an email out to the AMP listserv after this webinar that has the slide deck as well as some of the handouts, SOPs that we've kind of shared and kind of alluded to throughout the webinar. Our AMP Career Development Committee has been putting on webinars. This is our second one now. We are very much open to suggestions that you all have for future webinars. If you scan that QR code, you guys can provide any feedback for this webinar, as well as any suggestions that you guys have for future webinars. We want to make sure that our webinars are kind of meeting the needs of everybody and all of our members, and are really open to any suggestions that you guys have for topics. But again, thank you to all 5 of our panelists, and thank you all for joining, and hope you guys have a good rest of your day.